Medical billing is a time-sensitive, highly complex defense operation against payers, designed to keep the money you have earned. The 2025 data shows the scale of the resistance practices are facing. Across hospitals and private practices, total net revenue leakage from claim denials surpassed $48 billion in a single year. The initial claim denial rate steadily climbed to 11.8%, with Medicare Advantage rejections spiking 59%. Even when you win appeals, the fight drains margins. Providers spent $19.7 billion in administrative time simply to overturn denied claims. You are paying your staff to fight a system engineered to pay as little as possible, as slowly as possible. Every error means you lose money you already worked for. The second vulnerability is who you are relying on to fight that battle. Maintaining an in-house team is harder than ever, with business operations support staff hitting a 33.3% turnover rate. Every time a biller leaves, replacing them carries a hard cost between $9,000 and $12,000 just to get a new hire in the door. This timeline illustrates a typical 90-day onboarding window for a new biller. During this low productivity ramp phase, your revenue capture drops. A January hire rarely reaches full effectiveness in your systems until late March. When you take the median salary for a billing specialist and add in benefits, plus payroll taxes and facility overhead, a single in-house seat runs between $55,000 and $75,000 a year. You are investing heavy capital into a resource that takes months to train and has a 1 in 3 chance of walking out the door within 12 months. The math works strictly against you. General billing experience on a resume rarely equals fluency in your exact electronic medical record system. An expert in Athena often requires a complete retraining cycle to function in NextGen. Unfamiliarity breeds systemic mistakes. Currently, 68% of providers say clean claims are harder to submit than last year because unfamiliar staff input missing or inaccurate patient data long before the claim ever goes out. These specific software gaps fly under the radar. By the time management realizes an employee cannot effectively work a denial queue, the problem has already compounded into severely aged accounts receivable and widespread payer rejections. Fixing those gaps requires practice leaders or office managers to step away from patient care to retrain generalist hires on precise system workflows. Having a biller sitting down the hall offers a false sense of control. In practice, it masks a high-effort, low-accuracy operation where upstream errors constantly erode your profit margins. A growing number of practices are solving this by separating the labor of billing from their internal headcount. They utilize specialized outsourcing to bypass the hiring market entirely. Operations like Staffingly charge a flat rate for a dedicated billing seat, $399 per week, equating to roughly $20,748 per year. This waterfall chart compares the two approaches. The left column stacks fully loaded in-house costs, salary, benefits, replacement, and leakage, pushing past $55,000. The right column shows Staffingly's flatline cost. At volume, it drops to $349 per week, saving practices 6 figures annually. EMR-native outsourcing takes an unpredictable human resources liability and converts it into a strictly leveraged, predictable, fixed operational cost. Specialized teams bypass the EMR learning curve entirely because they arrive already trained and deployed natively in your specific workflows. These specialists work directly inside your native EMR via secure networks. They avoid the lag and transcription errors caused by clunky screen sharing or third-party interfaces. Before any patient data is touched, a strict security baseline is established. A business associate agreement is signed, and every team member completes full HIPAA compliance training. That foundation is reinforced by enterprise-grade certifications, including SOC 2 Type 2, ISO 27001, and HITRS, to fully protect your data framework. You get the operational seamlessness of an in-house employee without the severe security vulnerabilities of typical remote workarounds. Quality control requires highly trained personnel. Staffingly teams are composed of elite specialists holding strict AAPC and AHIMA credentials. This visual compares 2 workflows. These certified coders prevent leakage by catching complex modifier and ICD-10 sequencing errors before the claim is ever submitted, rather than waiting for a rejection. Those human specialists are augmented with AI tools. Smart routing directs work to the right coder based on payer type, and predictive workload management helps the team seamlessly absorb volume spikes. Supervisors conduct daily audits on a random sample of completed work, maintaining an error rate below 1% across the entire client base. Combining elite credentialing with AI automation builds a strict upstream defense system. It actively stops denials at the source instead of paying staff to chase them down later. If your practice currently enjoys zero turnover, employs highly credentialed billers, and you prefer managing administrative headcount over patient care, keeping your billing in-house makes sense. But if you are exhausted by the cycle of hiring, retraining, and watching your denial queue age out, you need a different structural approach. This flowchart outlines a rapid 14-day go-live timeline. It moves directly from a workflow kickoff and EMR connection through team training, straight into a 14-day pilot and a weekly performance dashboard. The transition carries minimal risk. After the initial pilot, the engagement is strictly month-to-month. You scale resources up or down with 30 days notice, completely avoiding long-term contracts. Moving to an outsourced EMR native model is a direct strategic upgrade. You trade the expensive illusion of in-house control for a highly scalable